Professor Mark Haas probably needs no introduction to his audience. He is the one who has revolutionized the concept of IgE nephropathy. So, he's a very senior renal pathologist, and without taking much time going in the details of the biodata, I'll request Professor Haas to present.
Good morning. No, the meeting has just started, but thank you for being here, and I'd like to thank the organizers for inviting me. It's a pleasure to be here, and I'm going to give a brief and somewhat fast review of kidney transplant pathology. These are my disclosures. I'm going to start with cell-mediated rejection, and then go into antibody-mediated rejection and chronic rejection. So cell-mediated rejection, the lesions seen most often in acute cell-mediated rejection is interstitial inflammation with lymphocytes and tubulitis, invasion of lymphocytes beneath the tubular basement membrane, often differentiated from the epithelial cells by a paranuclear halo. The number of lymphocytes in the most severely involved tubular cross-section is key to grading this. Here we see 5 lymphocytes in a cross-section, and here we see many more. The other lesion that we can see in cell-mediated rejection is endarteritis or intimal arteritis, in which there is infiltration of mononuclear leukocytes in arteries, and I must stress it's arteries, not veins and arterioles, directly beneath the endothelium. This may be mild with preservation of most of the luminal area, or it may be more severe, in which most of the lumen is occluded. Here's the endothelium here, and these are all leukocytes with some accompanying edema beneath the endothelium. Here, the muscularis of the artery is intact, but in rare cases, you can actually see transmural inflammation or fibrinoid necrosis. The Banff criteria for acute cell-mediated rejection have not changed all that much since 1997, and it describes 3 different types or grades of acute rejection. Grade 1, in which there is interstitial inflammation and tubulitis. There needs to be at least 25% of the cortex inflamed. If there are 5 to 10 lymphocytes in the most severely involved cross-section, grade 1A, more than 10, grade 1B. If there's intimal arteritis with preservation of most of the luminal area, this is a grade 2. If there's occlusion of more than 25% of the lumen, grade 2B. And if there is transmural arteritis or fibrinoid necrosis, this is a grade 3 rejection. If there's interstitial inflammation and tubulitis that involves at least 10% of the cortex but does not meet criteria for a grade 1 rejection, this is termed borderline or suspicious. This has been a problematic category almost since the inception of Banff, since some borderline lesions do appear to behave like mild rejection and others do not. Importantly, when grading inflammation for acute cell-mediated rejection, areas of interstitial fibrosis and tubular atrophy are not scored. The cells that are involved in the interstitial inflammation and tubulitis are predominantly T lymphocytes, CD3 positive, and thus the alternative term for cell-mediated rejection is T-cell mediated rejection, or TCMR. Here we see T cells infiltrating in a lesion of intimal arteritis. What is the clinical significance of these different Banff categories of rejection? This is an older study from the University of Pittsburgh, but still applicable today, showing the different grades of cell-mediated rejection and graft loss with borderline and 1A, T1 tubulitis, T2 tubulitis. These lesions tend to be quite steroid responsive and rarely result in graft loss. But 1B, cell-mediated rejection, in which there's more severe tubulitis, particularly when these occur after the first year post-transplant, are frequently associated with graft loss, and the more severe vascular lesions here are progressively associated with increased levels of graft loss. Although back in 2000, what was not understood is that some of these may represent mixed cell-mediated rejection and antibody-mediated rejection. So I mentioned here that for acute T-cell mediated rejection, BAMF does not score inflammation in scarred areas where there's atrophic tubules and interstitial fibrosis and tubular atrophy. This would not count toward the 25% of the cortex that needs to be inflamed. However, a number of studies, here this is the DCAF study, showed that interstitial inflammation in areas of fibrosis, especially when moderate to severe, is associated with increased rates of graft loss. And this is a study from Paris showing that when at least 25% of the sclerotic cortical tissue is inflamed, this is associated with decreased graft survival. Furthermore, in this study from Paris, they did protocol biopsies at 1 year post-transplantation. And when interstitial inflammation in areas of fibrosis, so-called 𝐼FTA, was present on the 1 year protocol biopsy, these patients were almost threefold more likely to have had a prior biopsy-proven acute cell-mediated rejection during the first year, suggesting that this 𝐼FTA may represent incompletely treated T-cell-mediated rejection or under immunosuppression. And in 2017 and 2019, BAMF added a new category of chronic active cell-mediated rejection. There needed to be interstitial inflammation in at least 25% of the sclerotic cortical parenchyma. And in order to try and eliminate overdiagnosis, the criteria were made more stringent, so there also needed to be inflammation in at least 25% of the total parenchyma. If there was moderate tubulitis, 5 to 10 lymphocytes in the most severely involved tubular cross-section, this was a grade 1A, and more than 10 lymphocytes, a grade 1B. This is what some of these lesions look like histologically. You can see here that there's inflammation with some edema in this area of scarring with atrophic tubules, and there is tubulitis here with up to about 7 or 8 lymphocytes, and here more than 10 lymphocytes. Chronic active cell-mediated rejection 1A and 1B. The problem is that at this point we're not really clear if chronic active cell-mediated rejection truly in all cases represents cell-mediated rejection, or is this a heterogeneous type of lesion? This was a study that 𝐷 and Ed Wong had done at our center, published in 2021, where 48 cases were studied with chronic active T-cell mediated rejection 1A or 1B, and we can see that only about 25% of these cases actually responded to treatment for cell-mediated rejection, steroids and or anti-thymocyte globulin. The response was somewhat better with grade 1A than grade 1B, but overall, as I said, about 25% response rate. So this appears to be a heterogeneous lesion, and there's some evidence from molecular studies that are ongoing that this is in fact a heterogeneous lesion and that it may be possible using molecular pathology to differentiate the responders from the non-responders. So I'm going to move on to active antibody-mediated rejection. The hallmark of antibody-mediated rejection in its active state is microvascular inflammation, infiltration of leukocytes, and this can be neutrophils or CD68 positive macrophages in the glomerular capillaries, occluding or partially occluding the capillary lumens. This is glomerulitis, and similar infiltration in the peritubular capillaries, peritubular capillaritis. Early on, this may involve primarily neutrophils, but somewhat later, primarily CD68 positive macrophages, and this is from that same biopsy, and we can see that a lot of these infiltrating cells are CD68 positive. However, microvascular inflammation is not specific for antibody-mediated rejection. It's a marker of endothelial injury, which can result from antibody interacting with the endothelium, but could also be due to recurrent disease or drugs acting on the endothelium, such as calcineurin inhibitor toxicity. So pathologists were very happy when C4D came along. This is a degradation product of C4, a component of the classical pathway activated by antibody interacting with antigen. And although C4D is relatively inert, it remains covalently bound at the site of C4 cleavage for about 2 weeks and is a relatively long-lived marker of a humoral response when staining by either immunofluorescence or immunohistochemistry in the peritubular capillaries. And early on studies showed that C4D was in fact highly specific for an antibody endothelial response, although the sensitivity varied based on methodology. And so in 2003, BAMF for the first time introduced criteria for active antibody-mediated rejection. There needed to be morphologic evidence, usually in the form of microvascular inflammation, immunohistologic evidence in the form of peritubular capillary C4D staining, and circulating donor-specific antibodies. However, not all cases of antibody-mediated rejection are C4D positive. And this has been shown in quite a number of studies, but this is one of the earlier studies showing this. This is a molecular diagnostic study done by the Halloran Group in Edmonton, Canada, and they looked at the impact of donor-specific antibodies, A, on graft survival as a function of either elevated transcripts showing endothelial injury, or NDATs, as well as C4D. And when NDATs were elevated and C4D positive, these grafts showed poor survival. When neither was present, the grafts did fine. However, even in the absence of complement, when there was antibody and endothelial injury, these grafts showed decreased survival, suggesting that antibody-mediated injury to the graft could occur even in the absence of C4D. So in BAMF 2013, the strict requirement for C4D was replaced by evidence of current or recent antibody interaction with the endothelium, which could be C4D, but could be more severe microvascular inflammation or expression of genes associated with endothelial injury. There still needed to be histologic evidence of microvascular inflammation and donor-specific antibodies. In biopsies meeting 2 of these histologic criteria, these were termed suspicious but not diagnostic for antibody-mediated rejection. The suspicious category was actually eliminated in BANFF 2019, but as we can see here from this data from the group in Leuven, Belgium, actually these biopsies showing microvascular inflammation and C4D in the absence of donor-specific, microvascular inflammation in the absence of donor-specific antibodies do have a worse prognosis than in the absence of donor-specific antibodies, the worst prognosis being in the presence of donor-specific antibodies. So there does seem to be this intermediate category, which in BANFF 2022 is now being called no longer suspicious for AMR, but microvascular inflammation, DSA negative and C4D negative, and hopefully this will stimulate additional studies to show the therapeutic response of this lesion. And finally, I'm going to go into chronic rejection in the last 2 minutes. The hallmark lesion of chronic rejection, and I'm referring primarily to chronic antibody-mediated rejection, is transplant glomerulopathy, duplication of the glomerular basement membranes seen on a silver or a PAS stain of the glomeruli. Transplant glomerulopathy is well known to be a bad lesion associated with declining graft function and increased risk of graft loss. It's also associated with donor-specific antibodies, particularly against anti-HLA class II. But notably, lesions of transplant glomerulopathy by light microscopy are only very rarely seen in the first year post-transplantation. Given that transplant glomerulopathy is such a severe lesion, is there a way to detect it earlier? And the answer is yes. These are data from Brian Nankervell and his group in Sydney, who studied 3-month biopsies by electron microscopy of grafts that subsequently developed after 3 to 5 years transplant glomerulopathy, and they noticed 3 findings: endothelial swelling, widening of the subendothelial space and early duplication of the glomerular basement membrane. And when all 3 of these lesions were present on early transplant biopsies, when these patients were not treated for antibody-mediated rejection, they invariably progressed to overt transplant glomerulopathy, but in many cases, this progression could be halted by treatment, suggesting this is an early lesion that is still potentially reversible. There are 2 other lesions of chronic antibody-mediated rejection that are not as specific. One is multilayering of the peritubular capillary basement membranes, which requires electron microscopy, has a similar pathogenesis to transplant glomerulopathy, endothelial injury, separation of the endothelium from the basement membrane, and laying down new basement membrane. Transplant arteriopathy, thickening of arterial intima with leukocytes in the intima, can be a lesion of chronic antibody-mediated rejection, but also chronic T-cell mediated rejection. And these are the BANFF 2022 criteria for chronic active antibody-mediated rejection. The 3 lesions I mentioned, there needed to be also evidence of active antibody interaction with the endothelium and donor-specific antibodies. And with that, I will close. Thank you very much for your attention.
Thank you, Professor Haas, for a very nice presentation. Now, 1 or 2 quick questions if there are audience.
We can take 1 quick question.
Any questions? Yeah, please.
We have the mics, yes, in between them.
Thank you, Dr. Haas, for the overview of the transplant biopsies rejections. I just wanted to ask that what is the role of diagnosing CG1A lesions on electron microscopy prognostically? Because once you see them early in the transplant period, it's fine. But once you see them after 2 years when already some amount of IFTA has set in, do you think there is any role of those? What is the prognostic value of diagnosing those lesions?
Okay, so the CG1A lesion, we see this mainly early on. To see pure CG1A late post-transplantation, we don't see this very much when there's no overt transplant glomerulopathy. When we do see it late, though, it's important to look for donor-specific antibodies. Whether it's still as reversible as early on, we don't know because we don't see this very often, but we need to look for donor-specific antibodies. Also, we need to consider other potential causes of this, such as, for example, chronic calcineurin inhibitor toxicity, or when it's appropriate, mainly recurrent thrombotic microangiopathy. But it's not a lesion we see late very often, unless there's been non-adherence and early antibody-mediated rejection.
Hello.
Okay. So if there are no more questions, yes, please.
Thank you, Dr. Haas. I had a sort of a hypothetical question. Do you think there's such a thing as a T-cell mediated TG, transplant glomerulopathy, which is being driven by a T-cell mediated rejection when we don't find a DSA or a C4D?
Okay. Well, I mean, some people believe in that, particularly the group at Albert Einstein have done molecular studies in which they found TG associated with expression of T-cell associated genes, but not antibody-associated genes. But I think that when we see TG in the presence of T-cell mediated rejection, I think this is probably mixed rejection rather than pure TCMR.
If there are no more questions, thank you, Professor Lal. Thank you very much.
Thank you.